going to hand over to our panel for today. We have Umala Steed, who is the Regional Lead for Palliative Approach to Care at Vancouver Coastal, Wallace Robinson, who's the Lead for Advanced Care Planning at Providence Health. And we also have, excitedly for me, two outreach workers with us, Ali Coburn and Doris Priest, who will be a part of the panel discussion as well. Over to you.
Thank you so much. Thanks, Tina. So just briefly, I will do a brief introduction here of our learning objectives. Our goal is to have conversation with Doris and with Ali about their experiences having conversations with people living with structural vulnerabilities, people living with addiction, mental health challenges, people who are vulnerably housed, Indigenous people who are living in the downtown east side and experiencing vulnerability as a result of that. So our goal is to really have them share with us. Omala and I will share a little bit of, we'll ask some questions based on our experience of what we've heard from Doris and Ali. We think you'll find their experience really rich in helping us understand how some of these conversations are happening, maybe outside of what we traditionally think as the healthcare team, and it challenges us to think how maybe to include them more in our team. So our goal is really to understand the context of the work that we've done at PHC and Vancouver Coastal in this Equity Serious Illness Conversation Collaborative. I'll explain a little bit of that before we get to the panel discussion. And then we'll talk a little bit about how our paradigm for serious illness conversations with structurally vulnerable patients has been shifting as we continue on this journey with this project. And then we want to, of course, really learn from the experience of our frontline partners how important their conversations are. Omala, next slide, please. So how our project got started, just a quick review. Many of you are aware of this, but for those of you who are not, we at Vancouver Coastal and Providence, like most health authorities across the province, have been using the traditional serious illness conversation guide developed at Ariadne Labs, Harvard University, developed by a team led by Dr. Atul Gawande. We've been using this guide and thinking of this guide as a best practice tool. But when we're starting to think about how these conversations happen, particularly at St. Paul's Hospital and in other settings where we work a lot with people experiencing vulnerabilities like addiction, mental health, homelessness, and other challenges, we found that the guide itself and the questions itself weren't necessarily helpful in guiding that conversation. So Umala, next, we developed what we called a guide for serious illness conversations with structurally vulnerable patients in hospital. That was work that was developed at the beginning of the pandemic, 2020, 2021. And we've been using that in acute care, in settings and in situations where conversations are to be needed. Our conversations are needed with this particular population. And then finally, Omala and I started work together. Next slide, or yes, thanks, Omala. Our next piece of work was to look at how these conversations happen in the community and to adapt some of the work that we had done in acute care for what these goals of care conversations look like in the community. So we had a working group that we developed together to do some work on this project. Doris was part of that initial working group. I think Ali came in a little bit later. And what we found as we were halfway through was there was a lot of work to be done, and there was a greater scope that could be utilized to further this work. So on the next slide, I'll talk a little bit about how our project eventually morphed into part of a national collaborative developed by Healthcare Excellence Canada where they're working with 9 partners across the country to develop individual projects that look at how to improve access to palliative care for people living with structural vulnerability. So suddenly we found ourselves, after applying to be part of this community and receiving funding for that, or for a 3-4 year project, we found ourselves part of a much bigger team. And we had funding to do some of the research and some of the specific collaborative and in-depth work that we wanted to do. And one of the first things that we found that we wanted to do, and sorry, just to back up a sec, our project specifically is about how can we improve access to palliative care, and really care of all kinds, but particularly palliative care for people experiencing homelessness, and other structural vulnerabilities. And our focus and our initial look at this work is in the downtown east side. So one of the things that we initially said and initially recognized is that we need to stop and take a step backward from the work that we initially had been conducting around a serious illness conversation guide with this community, and ask, what are these conversations? What do these conversations look like in the community? How are they occurring? Who are they? Who are leading these conversations, and how do they happen? Well, I'll turn it over to you.
Okay, so we started this, as Wallace said, joining the Healthcare Excellence Canada collaborative really gave us a chance to stop and think about what we were doing, and to think about how could we do this in the most community-led way possible. So initially we had a plan. We were going to take the conversation guide and adapt it. And then together our group said, let's toss that out the window and let's start again, which at the time, I will admit, it gave me some chest pains to think that we were going to completely change what we were doing. But I think in the end, first of all, the learning already has been extremely rich. And I think what we'll come away with is something that is going to be a lot more relevant for the people that we serve. And so the goals of the project, we called it Learning What Matters, Care Planning in the Context of Inequities. And so the project goals included understanding the care planning preferences of people living with serious illness, including substance use disorders, who are also experiencing health and social inequities. And that's sort of step one. Then we want to develop, implement, and evaluate patient-informed best practice guidance. It's going to be some kind of resource to support these serious illness type conversations. And in the process, through engaging with various groups in our community, we really hope that one of the byproducts is that we break down barriers and improve communication between organizations, because there's a lot of work that happens in the downtown east side, but a lot of it happens in silos. And I think anyone who's worked in public healthcare for a while has experienced the silo effect in various different contexts. So that's something that we really want to be mindful of. And so in terms of where we are now, to achieve objective number one, which that's really what we're focused on right now, and what this talk is going to focus on, we wanted to tap into the wisdom of our own working group to start to understand, how do we need to ask these questions when we reach out to the larger community, and how do we need to approach that larger community? So our working group consists of what I would think of as the usual suspects. So we have nurses, we have physicians, we have social work. We also happen to have 3 folks who work in outreach worker type positions. And so what we asked all of these folks was, what do the conversations look like in your particular context or where you work? How are the conversations happening? Who's having the conversations? And like I said, really using that information to help inform how we connect with the wider community. And so, so far, we've conducted 12 interviews with those working group members. And currently, we're in the process of doing some qualitative analysis, coding, and theming of those interviews. And then round 2 that's mentioned here on the slide, that's going to be with sort of our next group of community organizations who provide health and social services to folks experiencing inequities. So that's scheduled to start in about a month. And on the right-hand side of the slide, what you see is just a smattering of some of the initial ideas that came out of the interviews with those first 12 folks. And so some of the stuff that we saw really kind of aligned with ideas that we already understand and promote. So the idea that we all believe in the value of these conversations. We promote a multidisciplinary approach to those conversations. There's questions around whose job is it anyway. So those are the things that we weren't really surprised to see. What we wanted to share with you today, though, was some of what came out has really caused us to shift the way that we conceptualize these conversations. And so we've worked, Wallace and I think, in this serious illness conversation space for a number of years now. And a lot of the focus of that work has been on the role of clinicians. So people with lots of letters after their names and, with a specific type of training. And one of the things that we learned through this, the interview process with especially our outreach worker colleagues, is that we need to think more broadly about these conversations. And we need to think more broadly about who's having these conversations and what constitutes a conversation. And so high level, one of the things that we learned was that these what matters types of conversations can happen in really brief moments as a part of a regular interaction. They can happen on the way to an appointment. They can happen, in and amongst the context of a larger discussion about anything and everything. And the other thing that that came through really strongly for us was that our support workers, including community liaison workers, outreach workers, peer support, they're the ones that often witness these brief moments, brief but very important and impactful moments. And so they carry all of this knowledge and understanding of who this person is and what's important to them. And then the other piece that's really important here is that valuable information often is lost. So it's not necessarily passed on to the rest of the team. And partly there isn't an infrastructure, there isn't a workflow, there isn't a process for communicating that information. So I think that's going to be something that we look at going forward when it comes to coming up with conversation resources. And so at this point, we're going to shift. We've gone through the talky part, and we want to shift to a discussion with our two guests. So Doris Lee-Prest is an Indigenous cultural practitioner at Vancouver Coastal Health, who does a lot of her work in the Downtown East Side in Vancouver. And Ali Colburn is an outreach worker with the Outreach Overdose team. I hope I got that right. And they have been just two amazing additions to our conversation and our team. So I want to thank them both really for being here. And I'm excited for the chance for all of you to hear from them and from their experience. So Wallace and I have a few questions that we're going to kind of go through with them to just prompt some discussion, and then we'll open it up for questions from the audience. So that's how we're hoping to work this. So I'm going to start.
Can I interrupt for just a sec? We did have a question in the chat that came early in the conversation, which was how are structurally vulnerable patients defined?
Yeah, that's a really good question. Wallace, did you want to start us off?
Sure. So I think of a structural vulnerability as a vulnerability or an inequity caused by societal conditions. So, or other things that people experience external to themselves. I think, so Rachel put a definition in here. Social and health inequities include, but not limited to, poverty, homelessness, and vulnerable housing, substance and or alcohol use disorders, and racism. So those things that people experience that tend to marginalize people, that cause less opportunity, and certainly we know from much data contribute substantially, I think 50% at least of health issues and health problems that people experience can be tied to the inequities that they experience in society. Go ahead, Umla.
Well, I think you covered it quite nicely. So I hope that helps. And if more clarity is needed, please ask more questions. So I think at this point, I'll start by just asking a question. Maybe we'll start with Doris and then hear from Ali. Just can you tell us a little bit about how you learn what's most important to the people that you're working with in the community? Specifically, what do these conversations look like for you? Doris, do you want to start?
Sure. Those conversations actually happen just over time as you're building the relationship and you're trying to figure out who they are and what their needs are and what they deem most important to them. And it's, you know, as they begin to trust you and feel safe enough to be with you, then that's when you start finding out a lot more information. And, you know, if something has happened that they ended up in a merge or ended up with a hospital admission, then sometimes they'll start talking about, you know, what that felt like for them and what that might have brought up and how they're feeling and what they're thinking they need to, you know, for some, they want to get stuff in order in case it happens again. And for others, it's not so much, but it's definitely over time. And especially when they start feeling safe and trusted with you.
So it sounds like it's not sort of one sit down conversation, like we're going to talk about this thing. Okay. And Ali, what about from your perspective? How do you learn what matters?
I agree with what Doris has said. I mean, I've been working with the same population of people or the same group of people and the same clients mostly for about 3 years now. I've been in this position on the North Shore, and I've gotten to know things from people over time and learning what matters to people gradually. And I mean, that it really can't happen in a sit down conversation. I mean, if I was new to somebody and I sat down with them and I said, okay, let's find out what matters to you, they're not going to share that. You know, a lot of people have been through significant traumas, and they've faced, you know, some pretty horrific experiences, particularly in the healthcare system. And so they might not feel safe to share that with me because I wear a badge that says that I represent the healthcare system, and they could be fearful to share with me at first. But once I build that trust, people share with me over time, you know, what matters to them. And sometimes, you know, like Doris said, when if somebody has a hospital admission, maybe a bit more of a scary one to the ICU or something, then they might want to start talking about getting their affairs in order and their ducks in a row and stuff. And they will share about more of those things, and they will want to have it recorded somewhere what does matter to them. One client comes to mind where she really wanted, you know, her kids and her grandkids to know about part of their Indigenous heritage that was they hadn't known much about. She felt it was really important for them to know that, and so we sat down and recorded it for her, so that we can pass that on when the time comes. And that was, she said, you know, I can go it in peace as long as they know this, and so we made sure that that was possible for her.
Doris, how do you think that the conversations that you have with clients about goals or what's important to them might be different than what we think of as a traditional healthcare worker, a physician or a doctor or social worker? Sorry, physician or nurse or social worker, I meant to say. How do you think they might be different? Doris.
Can you say that again, Wallace? Sorry. There's a printer being
Sure.
moved in right now.
A little distracting there. So just wondering how you think that the conversations you might have with clients that you're working with might be different than the conversations that physicians or nurses or social workers might be having. How do you think they would be different? Or what's your experience of that?
Our conversations are always different. You know, I have a handful of clients that can pretend like they really understand what's going on and what's being said to them and understand the information that they're receiving with their diagnoses and stuff. But what happens when we're leaving your office, they really don't understand. And so it comes with a lot of questions about their health and what they can do and how do they, navigate their new world. And then, I also do palliative support for First Nations people in the downtown east side. And so a lot of our conversations, I try really hard to get involved sooner as opposed to waiting until they actually have that terminal diagnosis. And just because I would much rather have those conversations sooner with them when they're not so stressed out. But it's always a different conversation with us. And it's always the 10,000 questions that they are too afraid to ask their practitioners. Information that, at the time that they receive it, they're not ready to fully understand it. And it's a bit of a process, but if they're connected with a good team, I've worked with a lot of teams that are very, receptive, and whatever information I receive, I automatically pass on to them to make sure that they're aware of what's going on and they have an understanding of, where that person is at and how much they fully understand what's going on. It's very different. In the office is one conversation, outside the office is like, and if they trust you, it's a whole conversation with no holds.
And Ali,
Ali, what are your thoughts about that?
Yeah.
Sorry, I just pronounced.
Something
I
I
was a-
find happens a lot. People that I'll be working with, I will be aware that they're going into a conversation with their practitioner where they're going to be told that they have some sort of terminal diagnosis or, a serious illness. And, I'll know that that's going to happen. And sometimes I will come into the appointments with them. Sometimes I won't, but I'm generally aware of the conversation. Sometimes practitioners don't tell me they're going to have those conversations, and the client gets into the car after. One of my jobs is appointment accompaniment, right? So I'll just drive them to and from the appointment. They get in the car after and they tell me, my doctor just told me this, this, and this. What does that mean? And I will have to then explain to this person, you've received a terminal diagnosis and what a terminal diagnosis means. And, I'll talk to the practitioner later and they'll say, oh yeah, I told them that they're terminally ill. And I will tell that practitioner, I'll say, no, they didn't understand any of it. They had no idea that's what you said to them. You spoke in medical terms, and fortunately I've been around the medical world long enough that I can translate for people. And, I'm a person with lived and living experience. I've been on the downtown east side as a drug user myself. I also have a serious illness. And so translating, I can speak the street language and I can speak the medical language. And so translating those things is really helpful for people. And I can say it in a way that they're going to understand it. I might drop a few more F-bombs or whatever needs to be said, but I help people understand it in a language that they understand, where the medical professionals can't always speak that language. And that's why roles like mine and Doris's are so important, because, they say, why did this person leave the hospital? And I said, well, they didn't know how sick they were. They had no idea, because you explained it to them in a language they don't understand.
Ali, I just wanted to pick up on something that you said. So you talked about the use of medical jargon, and I think that we were all quite aware that we use too much of that. But I remember from your interview, you made another comment, and it was really around how we phrase things and how that can be interpreted or misinterpreted. I think the example that you gave was someone who was quite ill. I can't remember if they had something with their liver, but the message that they heard, or what the healthcare team told them, was that their blood work looked great.
Yeah, I remember.
Can you say a bit more about that?
Yeah, I was it was a nurse. I was in the room with my client. She was getting some more blood drawn from the nurse, and she goes, well, how was my last blood work? And the nurse goes, oh, it looks great, and didn't really elaborate on that. And so after, in the car, she says to her husband, who was waiting in the car, she goes, oh, I'm great. I'm not sick anymore. I'm fine. And I said, well, what do you mean? What do you mean you're fine? And she goes, oh, well, that nurse, she said, my blood work looks great. She goes, my liver's healed itself. And she goes, we can go party now. And I said, no, no. I said, you know, your blood work looks good for where you're at, but I had to tell this lady again that she's still terminally ill, where she was having this moment of celebration, thinking that she was no longer going to die because her blood work looked great. So, phrasing those things is really, really important. And yeah, it was a small slip that the nurse may have, she just wanted to give that lady some hope in that moment, but she didn't realize that not elaborating caused a lot of harm that day.
Thank you. And Doris, I wanted to come back to something that you shared in your interview, and that was, you talked about really breaking down the language or the concepts in ways that you felt your clients could connect to. And you gave the example of using an analogy about a mechanic, and I'm wondering if would you be willing to share that story?
Sure. I have a long time client who's a bit of a tinkerer and has quite severe CHF. He came into the clinic one day and was really, really unwell, and the nurses were panicked and they were like, he's got to go to hospital. He's got to go to hospital. And he's like, yeah, I'll go whenever I'm ready. But me also knowing that he didn't fully understand what was going on. And I got asked to call into his room, went into the room, sat with one of the nurses and him, and sort of had to break it down as, you got to look at your heart like an engine. And I was like, there's some things that happen that we can't just fix on our own at home in the middle of our garage. You got to, actually go into the shop and get a freaking tune up and have everything hooked up so we can see what's really wrong with it. I said, because right now, whatever I do, it's just a Band-Aid and you're going to be broken down the road, in the next day or two. And it's it was a lot lengthier than that, but it's really sort of breaking it down so that they understand, and they can relate to it better in an easier way. Mechanics are always the easiest. It's sort of, your car's broken down. What do? You take it to the shop. They understand that part of it. And it's just, yeah.
Yeah, I think that's a really smart way of, or intuitive way of connecting with someone in a language that they understand, right? Doris, and I think there's a lesson in there for all of us about how we communicate and how we use analogies like that or metaphors to help people understand, and how important that little conversation is in the ongoing conversation that we have with a client about what's happening to them.
Yeah, so the last question that I wanted to ask you both is around your experience in, and Doris, you did mention a little bit of this, but your experience in sharing what you know about the client with the rest of the healthcare team. How does that work? How has it been received? I think, Doris, you mentioned a situation where it had been quite well received. I'm just curious about your experience on the whole.
I think with the primary care units, any extra information can be very golden to them. They have, the more they know, the more they sort of understand the client, and just have a bigger picture and a better understanding, because a client's sort of priorities are not the same, can be very different to what we think a priority should be. For us in a medical field, their priority should be their health. But for them outside of the medical world, there's so much more going on for them. Not only is it their mental health or their addiction, it's their other family responsibilities. It's their other sort of, side jobs and hustles that they have to do every day as part of their survival. And most primary care units are, especially down here, are very receptive to it. The more they understand the client, the more they can sort of work around and do whatever work they can do on the side. But, you know, once we get out to, you know, specialists appointments and stuff like that, it's a little bit harder. They're not so inclined to see the bigger picture of the person and have a better understanding of what that person is. And, you know, I feel like the more information you know of the person, the easier it is for you to see that person and see the person as a whole, as opposed to just their addiction or just their mental health and or just their diagnosis, because there's so much more to them.
Yeah. It reminds me of, you know, one of the recommendations that we've started and promote as part of these goals of care conversations or serious illness conversations with people experiencing inequities is to ask about those goals or if they have any immediate needs before getting into a conversation about illness and you know, goals and wishes and fears around the future with their health. We need to address hunger, we need to address pain, we need to ask about housing, we need to ask about what's on your mind. Is there anything I can do to help you be more comfortable or to be in a place that we can have a conversation with your health? So it just recognizes the importance of addressing those immediate needs really up front before we're going to be able to have a more in-depth conversation about health plans.
Something that I found is really, really beneficial when you're taking somebody to an appointment, whether it's about a serious illness or anything in general. If there's somebody that is, you know, experiencing food insecurity, you know, taking them for something to eat before can be so beneficial. I know my brain works when doesn't work when I haven't eaten, you know, and to expect people to be able to hear information when they're literally starving, you know, or thirsty or, you know, really needing, you know, if all they're thinking about is the fact they need a smoke, you know, they're trying to run out of that appointment to go have a smoke. They're not going to be able to absorb the information, right? And so meeting those really basic needs first and making sure that people are comfortable. I know the clinic that I'm based out of, Health Connections on the North Shore, they often will give people snacks and things in the waiting room, and you know, they've got noodles and all kinds of things for people, right? Because that is such an important thing, to make sure that people have some food in their belly before going into, and it's something that a lot of people wouldn't think about before having these conversations, you know, asking if people have eaten or had something to drink, right? But it's it is important.
Yeah, I would say it's essential if we want them to think about and talk about the other things that we might have on our agenda. Yeah. So Ali, I know when we talked about your experience in sharing information with the rest of the team, I know you've had some varied experiences. Can you say a little bit about that?
Yeah, I echo what Doris would say with the primary care teams are usually fantastic. And, you know, I'm mostly based out of the one clinic, Health Connections, and many of the practitioners there, they like to hear these smaller pieces of information, and they find it very useful and beneficial. But I know, for example, I had a client in the ICU at Lionsgate a couple of weeks ago, and I was trying to get in to support. There was a very complex family dynamic happening at the bedside, and a lot of things that were going on that were very stressful. And I was going in there to support this situation, and they wouldn't let me in the ICU. I'm like, I work for VCH, like I have a badge, you know, please let me in. And they felt that, you know, it wasn't important for me to come in, never mind to, you know, hear what I had to say or to share with the care team or engage with that, right? You know, the nursing staff and the doctors of the ICU they wouldn't let me in. So I mean, and I do experience that kind of thing quite a lot. Like I'll go in to see a patient in the emergency room, and you know, they will treat me as kind of any old visitor coming in to see somebody. And I mean, I have the benefit that I do work for VCH and I can flash my badge at times, but sometimes, you know, a client's special outreach worker might be from the Lookout, for example, or Rain City, and they don't have that badge. And, you know, it's a lot harder for them to be able to come and talk to the doctors or the nursing team. And they're not seen as valuable players of the team when most times they have the most important piece of information and they're closest with those clients. You know, I know if if I was told I had a terminal illness, I would leave the appointment and I would phone my mom. And, you know, a lot of people that we work with, they don't have that person to phone. We are that person as their outreach worker, support worker. And, you know, we're the person that they're going to want to have those conversations with. And they're so important. And sometimes I will, you know, there's no matter how much I document and, you know, I chart an EMR, but no matter how much information I put in there, I can't translate or tell people in enough ways on a document, you know, what that client needs. You know, I just had a client landed in St. Paul's. He's in very serious condition, and they couldn't just take my chart notes to understand his client. I needed to phone them and explain more things, right? And so if I hadn't have known he was in there, if I worked for an external agency, then I wouldn't have had that opportunity to share that information that's greatly benefited his care.
I think, you know, Ali, that you're pointing to a few things that we've started to see in this project that we need to address. I mean, one is how we can empower you as support workers, as peer support workers, to be a part of the team and to ensure that your voice is heard. I mean, I think that that's one thing that's lacking in some areas. Obviously, I think you can think of lots of examples of where it's lacking. Another piece is, how do we communicate more effectively within and between the various teams that are supporting people who end up in hospitals? So we're all aware as much as we can be, respecting patients' confidentiality, but balancing that with ensuring that their wishes are known. So I think that that's another piece as well that we're recognizing is an important part of the work. And then I would just add one other thing that you said there, and that we noted in our acute care guide or recommendations around these conversations, is for us to be thinking about as healthcare providers, asking a patient, do they have any support workers? Do they have any people that they're close to in the community? Is there anyone that you would like to have be part of the conversation I have with you when we're talking about serious illness or goals of care, right? So we ask, we recognize, we reach out and contact you, we document that in the chart. So then when you come to see the patient, you're not held at the door, you're recognized and included as an important part, right? So I think it's another learning that we're taking away already from this work.
So I think now is probably a good time to open up to questions from the audience. And I see we've got one from Dominique, who's asking Doris and Ali, does the language of goals of care make sense to the folks that you work with? I love that question because terminology is it's fascinating. Is that a term that you guys use when you're speaking with folks?
No.
Yeah.
No, I don't use that term. I'm trying to think of how I would translate that. I would ask people in more direct ways, like, what do you need out of this experience? How can I, support you throughout this? And, what is it that you want to accomplish or do or achieve? Or I don't know, Doris, how would you translate goals of care? It's a tricky one, but I would never use that term.
I know for me, I've had the conversation a few different times, and it's one of the best, easiest times to do it is a post overdose. And it's whether they've ended up in a merge or, at that point in time, they've sort of thought about it. And for a lot of our addicts, they're like, they just ruined my high, and they're, pissed off about it. And, but it opens the door to have that conversation of, what if something did happen? What if, it ends up so bad that you're hooked up to machines and stuff? Like what are some of your wants and wishes, and how do you see that going through, and who do you want me to call? And if something happens, what do you want me to do? Where do you want me to call? Who do you want me to call? That sort of thing. So in some ways it's easier, but it's never goals of care or advanced care planning or anything like that. But I also am a firm believer in breaking up the conversation over time, step by step, not, doing it all at once. So I always chip away a little bit at a time to get whatever little information I can get.
Yeah, I find usually, or sometimes after people have gone missing as well, or after we've been unable to locate somebody for a number of days, after that's happened, it's been a lot easier to say, in case something were to happen, or, who can I call, right? And, and in those conversations, we find out more about people's family dynamics as well, right? Like some people might have a relative, or an auntie or an uncle that they're still in touch with that is compassionate and loving towards them, but would absolutely never want you to contact their parents or their children or somebody like that, because they don't have a good relationship. But then I would look at this person's chart, and that person that they didn't want to be involved would be listed as the next of kin, right? I was just supporting a client yesterday, and his spouse died 2 years ago of COVID. And he was with her for 8 years. They share a son that's 6 years old. And her body was released to relatives back east that she hadn't seen since she was 2 years old. And even though his family were listed as next of kin, they weren't. And so he's got this huge gap in his healing because he can't visit his spouse's grave. And and that's not what her wishes were, but unfortunately her wishes weren't recorded appropriately.
I think that's a big thing too. I think, when you ask somebody who their next of kin is, they'll just say whoever, but they also don't really fully understand the responsibility of being a next of kin. And then you realize for a lot of them, the person that's listed as next of kin has absolutely no clue what that person wants or what their wishes might be. And although they come in with really good intentions, it's still, for a lot of our people down here, they've been detached from their family for so long that their family doesn't really know who they are as well as they used to, or have any type of relationship or very little attachment with them, that sometimes families struggle making those decisions because they're like, well, I don't know what they want. I don't know what their wishes are. And then, then you have the other side of the spectrum where family just sort of swoops in. I've seen families come in when they haven't had any involvement with them for 10, 15 years because they've been so entrenched for so long. And they fly in and they all of a sudden take control. And this is what we're doing. This is what we want. This is how it's going to be done. But completely missing what that person actually wanted. And that person did not feel safe being able to express what they really wanted and how they wanted to go and all of that. So,
or were unable to express. I've had a few people that, they've been intubated, and while they're intubated, they've been as, heard of people that have shown up, and those people are like, I'm like, who are you? Like, I've known this person for a number of years. I've never even heard of you. You haven't been involved. And, they've made a list of who can visit and who can't. And, and I'm like, well, what about her boyfriend for the past 3 years? Why is he on the can't visit list? I'm like, that's the only person she would want here, and the family's dictating all these things. And, for some people, they will wake up and be able to use their voice. Some people will be too fearful to use their voice. And some people don't wake up and their end of life goals are not met. They have people around them that may even be their abusers in some situations. And that's not who I would want near me when I was going.
I think that's a good statement, Allie. Is sometimes, especially, a lot of people on the downtown east side, they've left their home for a reason. They've left their family for a reason. And it's, you know, we don't know what their past was like unless they tell us, but we can't assume that, you know, it was a healthy relationship there. You know, I think for most people, if you have a healthy relationship with your family, you're not really wanting to leave your family. And it's, I think we just need to be mindful of that, because over the years, a lot of people are like, oh, their family wants them to come home. And I always sit there and say, well, when's the last time they saw their family? And why did they leave their family in the first place? And it's a hard conversation for a lot of people, even with all of the, you know, cultural safety training and truth and reconciliation and stuff like that. That's a different subject. But anyway, just be mindful of it.
I would like to touch on
Yeah.
cultural safety a little bit as well. I work with a lot with many Indigenous people, and I something else I see is many of the Indigenous people that I work with are detached from their culture and detached from the teachings, and some of them are not. Some of them are very deep and connected to their teachings, and you know, they will have like an Indigenous patient support worker or something will be involved that's a part of the hospital, but this person has different cultural teachings than my client does. And so they'll be trying to give them medicines that it's actually, you know, offensive for that person to receive those medicines, right? And so being aware that not all Indigenous people participate in their culture, not all are comfortable around it, and some people feel very uncomfortable when they're having cultural things pushed on them. You know, they don't feel safe around their culture for whatever reason. So don't just assume because somebody's Indigenous that they want to smudge, for example. You know, ask people what they're, you know, what they wish for, and what part of their culture is important to them, and understand that, you know, Turtle Island's a really big place and there's a lot of different teachings all the way across, and having an understanding of that is really important.
That's huge. I guess
That's amazing.
it's, well, and Turtle Island is huge, but I guess some people don't know how diverse BC is. BC is the most diverse First Nations population all across Canada. And I am Nanaimo First Nation, which is also Nanaimo. My language from Nanaimo is not the same language as somebody up in Alert Bay, which is North Island. And we're on the same land, but we can't speak the same language. And the dialects change the further out you get. And it's, you know, Chilliwack alone has about 30 nations surrounding them, and they're all different. They have similar dialects in their language, but there's a lot of differences in their cultures, and their culture has different practices than my culture has. So smudging is not much of a West Coast thing either.
It's making me, when you share the richness of the relationships that you have and the support work that you do, it just makes me think of how organic the conversations are that you're having with clients, as opposed to how structured they often are in hospital. And how can we bring, you know, just had a conversation with actually Bina, who's on the line, and someone else from Providence, and we're talking about documenting in our goals of care power form, or wherever you document the conversations in your organization. How do we document? How can we empower the voices of yours and other outreach workers, and these qualitative conversations that you have with clients? We need to somehow capture them more. Something I think that we're challenged to do as healthcare providers in BC, to think about that question. Are there any other questions?
I see a question here. There were some goals of conversation guides. Oh, the guides. Where can you access those resources? So I will drop a link into the chat, but the original Serious Illness Conversation Guide and the adapted guide, I think you can find them on both the Providence website, probably. And I know for the RPACE team, which is the team I belong to at VCH, we also have those guides up on our webpage. So I'm happy to drop that link in there. And I think copy of the slides, and maybe we can add the conversation guides as well as part of the post-session resources, Tina.
Sure, that's fantastic. Yeah, great idea. And just Dominique, I see that you had replied that a synonym for goal, as in goals of care, includes need, wish, want, and I do think that those are words that I hear Ali and Doris using. You know, what are your needs? What are your wishes? You are engaging those conversations as we talked about, or as I mentioned earlier, but just in a more organic way and in pieces of conversation that we don't collect and value in the same way. Any other questions as we near the end here?
I apologize that our interviews were so rich and extensive, and I know we really just scratched the surface in our meeting today, and we do look forward to being able to share more with you over time. But I'm so grateful to the BC Centre for inviting us to join them, and to Doris and Ali for being willing to share their experiences. I think that you've really shifted our perspective. Well, I know you've shifted my perspective, and I think that I see a whole lot of possibility out there about how do we elevate and really recognize the important role that you play in supporting the folks that we're serving.
Thanks so much. I just one last thing I wanted to touch on was if it's something that people could take away from today is to remember when you're having these conversations with people, giving people a chance to respond and a chance to ask questions. I find that sometimes people that I work with it'll take them a few minutes to sit and think and process what they heard, and then they have the questions that come after. And just when they're about to ask questions or build up the courage to ask questions, the practitioner is leaving the room and saying goodbye and moving on to my next patient. If their time allows, allowing people to go and have a smoke, think about things, and then come back and maybe ask some questions a few minutes later, and giving people the time to share what they need to share. I had a client that she went into the clinic one day she'd fallen when she was collecting bottles, and she wanted to tell this big long story about it before she got to the point that she hurt her elbow. And she was also in for a new methadone prescription because hers had run out. And the person she saw just wanted to fill the methadone prescription. And then when she was sharing the story about bottling, she goes, yeah, we don't have time for that, another day. But what she was actually trying to say is, she thinks her elbow was broken. And then she got very angry with this practitioner, and practitioner was upset about it and put a big risk thing on her chart, and purple dotted her, and and then she said, I'm not leaving until I see somebody that actually cares about my elbow. And then she saw another person. The person sat with her for 25 minutes, and then eventually at the end of the 25 minutes she said, well, and then I fell and I banged my elbow, can I get an x-ray? And if people just allow the time for people to share what they need to share. She felt it was important to share the whole story leading up to how she banged her elbow, because she was embarrassed about the fact she fell, and she wanted to explain how she fell and why she fell, because she felt ashamed, and she didn't want people to think that she was stumbling and drunk as an Indigenous woman, when in fact she doesn't drink. And so that was why there was the big story leading up to how she fell. So just allowing people the time to say what they need to say is really important. And don't leave the room before people have an opportunity to ask those important questions.
I think the other important thing that I hear as you're speaking, Ali, is the importance of seeing people in the context of their own lives. So this person who came and was seeking care wasn't just a person who had hurt her elbow. This was a person with a whole life and spent time, you know, collecting ball. Like there's so much more to her that I think we need to see if we really want to serve people in the most client-centered way possible. All right.
So yeah, we are almost at an hour. That was fantastic. Thank you to Wallace and Ali and Doris and Umala. Thank you for the work that you're doing around this. Makes my heart so happy when you said you started all over again, brought community to the center of your work. This is exactly what I love to hear. And I hope that you'll come back again and share with us some more of how this work is evolving and shifting, and I think and hope will make an impact across the health system in particular, in terms of recognizing, in my opinion, the healthcare team is more than just the healthcare professionals. I think that's a really important piece. So thank you to everyone for attending today. As I said, we'll be trimming up the recording and making sure that it's nice and neat and tidy for folks. We'll have some summary notes that I've been taking throughout the day. We'll get those resources packaged up as well and send that all out to everybody who has attended and also everybody who has registered. We are in the process of planning 2024 Serious Illness Conversation, Goals of Care, and ACP sessions for ECHO. So if you have ideas and suggestions, please let us know. We've dropped a link to a survey, post-session survey, that will take you a couple minutes to complete and will help us understand some of the focus and themes of future sessions that you'd like to see. In the meantime, I encourage you to look at the center's website. We have a few more ECHO sessions in some of our other series that will be happening this month and early in December. We have 2 sessions within our grief and bereavement literacy series. Next week it's on pregnancy and infant loss, and during December it is around grief and loss during the holidays. And then we also have a series we call All Together that is trying to bring the health system and community services together. And our session in December on that is developing dementia inclusive spaces for community access, participation, and engagement, or DEMScape. So lots of ECHOs happening. You're welcome to attend as many as you like, and we hope to see you again soon at either an SIC or some of these other ECHO series. Thank you, everybody.